This is a web-based instruction for scrub nurses and doctors in urological care. Doctors for Africa and other organizations provide urological care in African hospitals. The purpose of this lecture is understanding of the urethral stricture. The penis consists of several parts. There is the corpus cavernosum, the swelling bodies, and there is the corpus spongiosum in continuity with the glans penis. The urethra is situated within the corpus spongiosum. In urethral stricture disease, it is important to estimate the length of the stricture and the location. This is important for decision-making about the exact treatment. The urethra and corpus spongiosum are covered by the bulbospongiosum muscle, and there is innervation by perineal nerves. The urethra is situated within the corpus spongiosum, but it's not at the exact place all over the urethra. In the penile part, the urethra is situated centrally in the corpus spongiosum, whereas more proximal in the bulbar area, it is eccentric. At the level of the membranous urethra, there is no corpus spongiosum anymore at all. A urethral stricture is a narrowing of the urethra leading to complaints of urination. It might be mild with a reduced stream. It might be moderate with a need to strain, severe with the inability to pass urine, or extreme with a complete blockage. The cause of urethral stricture could be infection like a urethritis or sexual transmitted diseases. It could be lichen sclerosis, a skin condition that also may affect the glans penis and the meatus, as well as the foreskin. Trauma by direct trauma, as in road traffic accidents or straddle injury, urethral manipulations, or previous endoscopic therapies. In many cases, we do not know the exact cause of the urethral stricture. Symptoms may be a weak stream, straining, painful urination, infections, or bloody discharge from the meatus or bloody urine. In patients with a small prostate, you should consider urethral stricture in these symptoms. For diagnostics, the first step could be to do a trial with a catheter. If you can pass a catheter up to the bladder, then there is no urethral stricture and no need for further investigation for urethral stricture disease. A retrograde urethroplasty is the next step. If that is not possible or there is a complete blockage, a micturition cystourethroplasty is the other option. In this case, you will need to fill the bladder through a suprapubic catheter. A urologist would do a cystoscopy. Here you see some examples of a retrograde urethroplasty. It should be in a 3/4 oblique position and projection to get a complete overview of the urethra. If you only have an anterior-posterior view, you can only judge the penile urethra, but you have no information at all about the bulbar area. This on the right-hand side is a small urethral stricture, and at the right lower part you see a long bulbopenile urethral stricture. The locations of the stricture may be meatal, fossa naviculare, the penile urethra, the bulbar urethra, membranaceous, and bladder neck. For treatment, principally there are some options. First is to do a dilatation. Preferably, this is done over a guide wire to prevent extra and further damage of the urethra. A direct vision internal urethrotomy like saxe, could be done. In this case, an instrument is introduced in the urethra, and with a cold knife you can cut the stricture. The indications for these two procedures are primary short bulbar strictures. In penile stricture, there is only indication for a dilatation, not for a DVIU. The success rates of these procedures are limited. After a first procedure, there is a 60% chance of cure. If you need to do the procedure again, the success rate drops to 30 to 40%. If you would do more procedures, you will have a 100% guarantee of recurrence. An alternative is a urethroplasty. You could excise this stricture if it is short. In this case, you do an excision and primary anastomosis. With longer strictures, you can do a substitution with a graft. The long stricture is being incised. This leaves you a gutter, which you can cover like a covered wagon. And for this covering, you can use materials like buccal mucosa or lip, foreskin, or scrotal flaps. The disadvantage of scrotal flaps is that there are hairs and this can cause problems in future. Patients are placed in a lithotomy position and there is an incision made between the anus and the scrotum. Then the urethra is dissected. In excision and primary anastomosis, the exact place of the stricture is identified, the stricture is removed, and then the ends are re-anastomosed again. In onlay procedures, you can go either dorsally or ventrally. It is important that you know what is the dorsal part of the urethra and what is the ventral part of the urethra, as indicated here on the right-hand image. In ventral onlay procedures, the urethra is cut at the ventral end. Here you see wide openings, and here is a catheter, and in the midline you can see the stricture. In this case, you will take a graft and suture it on the edge of the urethra, and then it's being covered by the spongious tissue. In dorsal onlay procedures, the urethra is freed. It is cut open at the dorsal part. A patch is attached to the corpus cavernosum. Then the urethra is placed over the graft as some kind of a hood. Buccal mucosa can be harvested by general anesthesia or also in local anesthesia. You could take tissue from the inner cheek, the lower lip, the upper lip. It is important to identify the ducts of the parotid gland. In buccal mucosa, the inner cheek wound often is closed with a suture. The lower lip is always left open because of the risk of contracture. If you combine bilateral inner cheek and inner lip, you can get a graft of about 15 to 20 centimeters. Post-operative care is just mouth washing. The wounds in the mouth will heal quickly. After completion of the procedure, a catheter is placed. It is very important this catheter is not dislodged. It must stay in place. Therefore, there is a balloon on the catheter. It should always be taped to the lower abdomen, and there should be continuous drainage because you do not want to have any urine leaking alongside the catheter. The catheter will stay in place for about 2 to 4 weeks. Perioperative antibiotics will be given. Bladder washout with povidone in case of an indwelling catheter or a suprapubic catheter. There is general anesthesia or a spinal anesthesia. Post-operative opioids and NSAIDs are prescribed. There's no need for prolonged antibiotic treatment, and post-operative mouthwash is prescribed in the buccal mucosa procedures. It is important to give patients prophylaxis for deep venous thrombosis. Ideally, preoperative culture and sensitivity is done, so gentamicin and a third or fourth generation of cephalosporins are given, and the povidone bladder washout. In urethroplasty, you could get wound infections and hematoma like in any other kind of surgery. There could be hematuria, and a big problem is catheter dislodgement. There could be bladder spasms. This means that the bladder contracts due to irritation on the catheter and the balloon. Patients will feel this as an urge to pee, and there also might be some leakage of urine alongside the catheter. You can prescribe oxybutynin or buscopan or NSAIDs. Seldom there is bleeding at the donor site or damage of the parotid duct. In case of catheter dislodgement, always inform the urologist. Act immediately. Reinsert the catheter, but there is a risk of false passage or damage of the precious urethroplasty. Use a lot of lubricant. Do not use any force. Ideally, insert the catheter over a guide wire. How to introduce a catheter over a guide wire. Our teams should provide you with a catheter with an open tip and a guide wire. The guide wire is a glide wire. It has a slippery hydrophilic coating. Use a sterile work field on the legs. Make the guide wire wet using a syringe with water or normal saline. Introduce a guide wire in the urethra. This should go very easy. And if you're short of the position in the bladder, you can railroad the catheter over the guide wire. The opening of the catheter should always be at the tip. If there is no central open tip, then you can make a puncture hole with a big needle. Be sure that the catheter is at the right position. Post-operatively, we might make X-rays. First, make a reference X-ray without contrast. Fill the bladder with radiological contrast and then remove the catheter. Have the patient void and make an urethroplasty during voiding. If there is no extravasation, the catheter can be left out. In cases of extravasation, the catheter should be reinserted and the urologist should be contacted. The catheter will be prolonged for 1 to 2 weeks. Here you see an example of some extravasation. In cases of a positive urine culture, preoperatively, there is indication for antibiotic treatment after removal of the catheter, but only if a oral medication is available. In cases of complication or questions, do not hesitate to contact the urologist. You should have their contact numbers. Thank you for your attention.